Hi, everybody. Welcome to the lecture on ultrasound in bleeding disorder treatment centers. And we're really happy to have you here today. And we hope that you guys do learn a lot and plus enjoy just learning a little bit about the ultrasounds that are done in offices and that could possibly be done on you or your children. So we hope that this is informative and that you learn a lot from it and can go to your clinics and ask any questions that you have, or you can always get in touch with us who did the lectures. I'm going to turn it over to Natalia, and she's going to do a little housekeeping about how to use the system that they're on.
Hi, everyone. As you've seen in the chat, I'm going to admit one more person. My name is Natalia Winberry, Manager of Education at NHF. I'll be managing our chat space for this evening, but I also wanted to let you know that tonight we will be having our presentation will be in Mentimeter. And so right now is a really great time to go to www.menti.com and use the code 91801423. And go ahead, grab that second device, put in the www.menti.com and put in the code at the top of the screen, and you'll be able to interact with us. And I'll turn it back over to Cindy.
Okay, so welcome again, and here we go. So if we could advance to the first slide, please. Thank you. So the mission for NHF, as you guys know, is for education as well as a foundation for inherited blood disorders that addresses prevention, complicated disorders with bleeding disorders, hemophilia, von Willebrand's, rare disorders, those folks with inhibitors, etc. And we want to enable advocacy and people and their families to thrive as much as possible. And hopefully we do this by some of the lectures as well as the conferences and some of the meetings that we have so that we can all get together and talk about what's best for everyone. So that's our goal. And we hope that this does play a small role in that. So thank you very much. And I keep trying to hit my button to advance the slide, but that doesn't work. There we go. So if you guys can all put in your chat box, or if you signed in to Menti with that code, the code is 91801423. And you can go to this little map of the United States and just drop a pin for where you're viewing us at tonight. And if you don't have the Menti code into your phone, you can just put in the chat box, please put in the chat box where you're watching us from tonight, what state and possibly what city. That would be really interesting for us. And we'll go forward from there. So I'll give you about 30 seconds to go ahead and do that. Tell us where everybody's at. That would be nice. Oh, Kansas City. All right. Welcome, Naomi. Let's see. Looks like I'm looking down, but I'm just looking at the chat box here. And it's really nice to get people from all over the country. Too bad I can't hear your accents. That's always fun. Then we can make good guesses at where we're from then. Somebody from Georgia. All right. Somebody had the Menti system on. Good job. And Bethlehem, Pennsylvania. Cool. The Christmas city. Oh, I like that. That's very nice. I never thought of that before. And my sister and brother were born in Philadelphia. Victorville, California. That's up the road a bit. That's probably about 60, 70 miles from me in Los Angeles. And all right. Well, those are all the cities we have for now. So welcome, everybody. And we will see where we go from here on the map. But let's advance to the next slide. Oh, and San Diego. Hello, San Diego. So when we talk about ultrasound, we want to not only, I have to get rid of this little box over here. 1 second. There we go. And when we're talking about ultrasound, we want to know, is this easy to do? How long does it take to get information? How long does it take for us to put the probe on somebody and actually see an image? Is it safe? Is it relaxing? Is it easy for us to do ultrasound for a patient? And as you can see in the image on the left side of the screen here, the person is holding the ultrasound probe and their arm, and literally by the time you put that ultrasound probe on the skin, within 2 to 3 seconds, you see an image on the screen that shows you the inside of the human body, which is absolutely phenomenal. And so it takes 2 to 3 seconds to get an image and to do an ultrasound. The only uncomfortable possible part of this to a patient is that the gel is very cold. But most of us use little warming to make our gel warm before we put the gel on the patient. So that's one thing that we always warn the kids about, is this is going to be a little bit cold when we put it on. But other than that, this is a very comfortable modality. Sometimes the positioning might be a little difficult if someone has had a bleed or they're in pain. But other than that, it's a very easy, very acceptable for the patients. They usually like it because they can see the inside of their body as well as we're putting it on them. Next slide. So what is ultrasound and how does it work? Ultrasound is a form of a sound wave. So as the sound wave comes out of the head, the sound beams come out of the head, we call the transducer, and the waves go into the tissues. When that happens, they go out, but they also come back. So the ultrasound head sends them out, and when they go into the body tissues, they bump into things. And when they bump into a tissue like a tendon or a bone, then it bounces back. And the ultrasound transducer head also becomes a receiver. So as that happens, we not only send out the sound wave, but as it receives the sound wave back, depending on the speed and the strength, the sound wave bumps and comes back, or it goes out and it comes back. So depending on what tissue it hits, it will bounce at different speeds and different strengths. And that's what gives you the grayscale image on the screen that you see, is how fast that rebound is as it comes back into the sound head. Next slide. So we get the picture that's created by the bouncing sound waves. That's the image that you see where you're looking at the baby here in the center picture. And that's created because of the bounce back of the sound waves off of the different tissues. And you can see that some of them are more of a bright white and some are black. And we'll explain that in a minute. So ultrasound has been used since the 1940s in body imaging in the United States and around the world. And we've used it to visualize pregnancy, infants, cartilage, bone surfaces, different tissues. And one specialization that has used it extensively is rheumatologists for arthritis. So that's where we get a lot of our background when we're using it for orthopedics and specifically patients with hemophilia. A few of the uses today are, again, by rheumatologists, orthopedic surgeons, or just orthopedic physicians that are not surgeons in their offices, interventional radiologists to do imaging, and when they put the needle in to give you an injection in a bursa or a joint or something like that. Physicians can do that with an ultrasound guided imagery. Sometimes when they do epidurals in your spine, things like that, they'll want to do it under guided imagery. And then they use an ultrasound probe and they put the needle underneath it so they can see exactly where it's going. Internal medicine, so they can see your gallbladder, do you have gallstones, your kidneys, your pelvis. So all sorts of things they can do with ultrasound. They can see blood clots, they can see echocardiogram, how your heart's beating or if the valves are working right. They can also see blood clots or blood flow, the direction of blood flow, is it strong, is it not? So they use it for a multitude of things. And now in the last 4 or 5 years, we're starting to use it in hemophilia treatment centers and bleeding disorder centers around the country and around the world in order to see bleed or no bleed, chondral surface damage, no chondral surface damage, which means chondral surface is the bone, or is there cartilage damage or no cartilage damage? So we're using it for a multitude of things when we answer questions about patients with hemophilia and the health of their joints as well. Next slide. The machines come in varying stages and complications, and not complications, but they're very, handhelds are very easy and they get more complicated as they get bigger and bigger. So you have your handheld that just plugs into a tablet or even your phone. And that would be between $2,000 and $5,000, $6,000. Then you have your laptops, which just looks just like a laptop computer. And you can use a laptop. It's very portable. If your bleeding disorders center does a lot of outreach, they might want a laptop so that they can take it throughout their clinics that they service. But both of these have a little bit of a limitation in if you're going to use it for research. They don't do as much measurement. They don't have as many tools on board as you can get with your big console units, which you see on the left. The console units are the ones that if you're going to do a lot of research, that's the type of machine you would want. Now, the other machines are just fine. If you're not going to do research and you're just answering the questions immediately, point of care ultrasound and investigative, they're totally fine. But if you are going to do research, I would suggest the console machine, simply because it has more measuring tools, it has more bells and whistles, it has more ability to do things with the image post-processing and before you take it off the machine, pre-processing and post-processing. Okay, next one. So with ultrasound imaging, why is it a preferred modality over MRI and CT scan? The number one huge reason that it's a preferred modality is that there's no radiation. So no radiation and no thermal effect. So when you have the treatment ultrasound, like you get in a physical therapy office, treatment ultrasound has a thermal effect. And so it's not the same. That type of ultrasound can be damaging if left in one spot for too long, because it has a thermal effect. This type of ultrasound, which is imaging ultrasound, not treatment ultrasound. So imaging ultrasound has no radiation and no thermal effect. It also does not require, excuse me, any sedation of children in order to have it done. And so we can do it just with the children being distracted and mom and dad, you know, playing with them, and we put their joints in the positions that we need, and then we go forward with the ultrasound evaluation. But in an MRI or a CT scan, they need them perfectly still all the time, and so they would need to use sedation with a small child. When we are doing any dynamic imaging is super fun. This is the world of the physical therapist. So dynamic imaging is where we actually ask the patient to move. So as they move that joint, and we can put our ultrasound probe on it, and if we do that, we can actually watch the bones move and how they move next to each other. Does one have a bone spur, or does the cartilage, one side have cartilage damage? Are there bony pieces inside? Have they had a little sliver or something? We can see all of that with our ultrasound imaging and dynamic movement as the patient moves their body part. So dynamic imaging is really nice for the physical therapist, because then we can say, well, when we're doing exercise or when we're testing this person, we don't want to push any farther than that, because if we do, then the bone spur goes and squishes it every time. So we don't want to have that impingement or that scrape of that bone spur on that other tissue. So we're going to stop short of that when we do exercise or when we do our testing. So with dynamic imaging, we can see other things happening inside the joint or inside the muscle or the tissue, and that gives us more information on what we're dealing with. The availability in the clinic, it's available immediately. Our physician here, Dr. Kwan or Chris, our nurse practitioner, will say, hey, Cindy, can you do an ultrasound? I can do it in 5 or 10 minutes, and we have the answer. So it's phenomenally quick and easy, no radiation, no thermal effect, no sedation, and we can also do dynamic imaging. Okay, next. For ultrasound, when we're comparing it to an MRI, which is considered the gold standard for musculoskeletal imaging, then we would, when you're showing all tissues, not just bone. For bone, it's still a normal X-ray is the gold standard if you want to see bone. But if we want to see other tissues, then there are several things you can use, and that would be CT scan, MRI, or ultrasound. Now, MRI versus musculoskeletal ultrasound, one of the reasons that musculoskeletal ultrasound is better for what we in the Hemophilia Treatment Center and Bleeding Disorder Centers are doing is that a pixel size of an ultrasound machine, depending on which machine, like the laptop or the console, you're comparing it to which MRI machine, whether it's a research machine that has smaller pixels, or it's a general machine like you would go to your imaging center in a hospital and get an MRI done. Those are bigger pixels. So ultrasound has a little pixel, MRI has a big pixel. So it's just like your television focus. If you go to Best Buy or Costco and you buy a TV that's 750 pixels, then you can compare that to a TV with 1,500 pixels, And the TV with 1,500 pixels, so meaning the pixel is smaller because there's twice as many, the focus is like, whoa. So your focus is so much better if the pixels are smaller. So on an ultrasound machine, our pixels are 4 to 20 times smaller, depending on the machines that you're comparing to each other. So because our pixel size is smaller on the ultrasound machines than an MRI machine, our ultrasound has better focus and better definition of the thing we're imaging. Next. The other comparison that we make between ultrasound and MRI is that on an MRI machine, an MRI takes slices. Okay, and they take slices usually every 4 millimeters, but it depends on the machine and if it's a research machine or not a research machine. So what we're going to do is, if we're an MRI, we're going to take slices every 4 millimeters, and then we're going to take what's on those images and we're going to average it. And then we're going to make these beautiful images for you. But those images don't see anything in between the 4 millimeters. So you have 3 millimeters worth of stuff that the MRI machine did not image. So it's just averaging those 4 millimeter slices, and that's what gives you the image. Where if you look on the right side of your screen, the ultrasound, when I'm doing ultrasound, I'm going all the way along every single little bit. So with an ultrasound sound head, I'm imaging everything. There are no slices. So what's there is what I see. It's not an average of anything. So with ultrasound, we see all of it. It's not an averaged image. So ultrasound gives us a much more complete and a much more focused image than what we would see with an MRI. Next. When we're talking about MRI versus CT versus muscus, or muscus is probably what I'll say for the rest of the lecture for musculoskeletal ultrasound, because it's shorter and easier to say. So when we're comparing MRI, CT scan, and muscus, we also know that muscus is preferred if we want to see fluid. And that's because fluid, MRI and CT scan can tell if fluid is present, but it cannot tell if fluid has blood in it. All it can say is there's fluid, doesn't know what it is. But if you remember, we talked about those sound waves that go out of the sound head and then they bounce back. Well, if it hits something, it bounces back. If water isn't anything, and so it just goes through water. Well, MRI and CT scan, it just goes through the water. With a ultrasound, because of the reflectors, if it hits something, it reflects back. It will show us blood speckles at 5% of blood in your fluid. So if you've had even just a little bleed, that you take the whole amount, if just 5% of that is blood, then it's going to show up with little teeny speckles in that fluid. And the reason for that is because heme, or the iron component of the blood cell, is dense and it's thicker than the rest of the blood cell. And because of that, as this sound wave comes out, it hits the little teeny heme and then it bounces back. And so it'll show it as a little speckle in the fluid, a gray speckle. So out of the 3 imaging modalities that we use for soft tissue, joints, bones, etc., only muscus can tell us whether or not there's blood in the fluid that we're seeing. Next. So when we talk about the use of ultrasound and muscus in the clinic, we have to think, okay, what do we use it for? Well, we do not use it as a replacement for our initial evaluation or our manual skills that all of us use as physicians and physical therapists and nurses, nurse practitioners, and physical physician's assistants. What we use it for is an extension of that. So we still do our evaluations, we still do our objective and subjective evals and our manual, and then we'll use it as an extension. So it does not replace it, it is in addition to our already given evaluations. Next. So we're going to use ultrasound for 4 things in our clinics. We're going to use point of care, longitudinal and comparison joint progression, whether it's negative or positive. we're going to use it for investigative, and we're going to use it for research. So when we're going to use it for investigative, that means we're going to go a little bit further than our protocol images that we would normally get to just go, let's get a baseline. And we'll talk about that. Go ahead and next slide. So for point of care, this is something where, as we saw in the first slide, we just put the probe on and immediately we can see something. And that's when a patient comes in with a problem and we want to know, is there a bleed or is there not a bleed? Is this more arthritic than it is a bleed? And they're older, so now they have arthritis in those joints. So this will tell us blood or no blood within about 5 to 6 seconds. 2 or 3 seconds to put it on, but sometimes it takes us a little bit to hunt. Is there a current bleed or no bleed? Are the cartilage and the chondral surfaces or the bony surfaces smooth and nice? Is the cartilage healthy? It can also tell us, is the synovium or the lining of the joint, has it thickened because of the bleeding and the irritation inside from the blood? As we all know, blood is very deteriorous and deteriorating to the joint cartilage and bone, but it's very inflammatory to our synovial lining. Is there soft tissue hematoma? Did the person have a contusion or a bruise? Did they hit something or get bumped? And now they have a hematoma in the middle of the muscle or somewhere. Is there a progression of the healing? Is there a lack of healing? Are they progressing or are they kind of stuck? Maybe they need some other intervention. Okay, next slide. So that's point of care. Then we're going to talk about a little bit of, we already talked about that, what we do. It can answer the questions of bleed or no bleed, yes, no, stage of healing, Doppler for inflammation, and dynamic imaging, as we talked about. If they have a bone spur or something that's hurting every time they do that, we can put the probe on, have them move and go, oh, okay, well, don't do that. And so it's something where we can see why they're having a problem to see if that needs intervention or if that's something that's not going to resolve over a short period of time. And then we'll have to think of another treatment remedy for that. Next. So longitudinal comparison or joint progression, whether that's a positive or a negative, is just watching a person's joint over time. So we get a baseline, and that can be either when they have an injury or hopefully it's when they don't have an injury or a bleed. So we can see what's normal for that patient. And then we just watch them over time. And we can compare it to when they had no bleed to now they might have a bleed. And now we can watch the bleed resolve over time. Or we can see if the bone cartilage is changing over time and maybe do it once every 3 years or so. If they're having no bleeds and they're not having a problem, awesome. And then we don't have to do it as often. We can do it if they're having bony changes or if they're feeling something that's not the same as it was before, or if they had a sports season and the parents want to know, is it safe for them to continue? Well, if you have a baseline from a year or two before that, and now they played a year of whatever sport they were interested in, and now you can do ultrasounds, in the next after the season or a little bit after that, and see if there's any bony changes that are negative, or possibly from getting increased motion and fluid and lots of lubrication in those joints, it may have helped the cartilage to become more supple and help the whole joint in and of itself. So whether something is becoming very detrimental to a joint or whether something is positive for a joint, we can see that when we do these ultrasounds over time and compare it to itself. Another thing we can do is compare it to the uninvolved side. So if you have a 5 or 6 year old and you're not sure what's normal for them, if they have the other side that they've never had an injury on, compare it to the other side immediately. You could not do that with an MRI or a CT scan or an X-ray. Because they have radiation, there's not a medical reason to irradiate that other side. And so the doctors would never allow that. But in ultrasound, we can just go, hey, wow, let's compare that to the other side. Boink. And we can see what's normal for that child on their unaffected side and compare it to what's going on as we look at the other side and its healing stages. Next. So when we're looking at investigative ultrasound, what that means is we have what we call protocol shots. And we have 2 scoring systems. We have a JADE and a HEAD US. And what that means is those have instructions for the person doing the ultrasound. The instruction is, we're going to pretend here, this isn't for real, but if you were going to do a wrist, if I'm going to do a wrist, I want to do a shot here and a shot here, okay? So that would be what the JADE or the head US, if I would put in the chart, I did a wrist JADE, they would know that I did an ultrasound image here and an ultrasound image here. But what if their problem is right here? I didn't do an image right here. And so an investigative ultrasound is going, okay, well, with those protocol shots, we didn't find anything. So now I need to investigate a little further. I need to investigate, what is the patient's problem? When do they hurt? What's causing them the issue? Did they have a hematoma, or are they getting this from things that they're doing, like typing or doing things with their hand? So like I say, usually the physical therapist is the one doing this in your clinics. It doesn't have to be, but that's usually the person doing it because their knowledge of how the body works, anatomy, how we want to look at things, especially when we're looking at it as it moves in space. Those things are usually very much up the physical therapist's alley. And so we usually are seeing these ultrasounds done by physical therapists within the bleeding disorder centers. Again, they don't have to be. Our physician is trained as well, and she's very good, but that's the usual. Okay, next slide. When we're getting a baseline image, again, we would like it to be when someone is not injured at all. And that just shows us what's the normal for that patient. And then we can compare it if we're doing longitudinal things, if we're comparing longitudinally, and if we're doing research, we can take that baseline and then we can compare it to before they were on prophylaxis. And then if you start prophylaxis, we can see 2 or 3 years later how the joint looks. Was it better? Was it worse? Was there no change other than expected with aging? Are there longitudinal changes within the patient's self or compared to other patients of the same age groups with different interventions, whether that's their own activity of sport, whether it's a change in age, whether it's a medication, an infusion product, whatever it might be that we're comparing it to. And also patients, we would love to hear from the community with research questions that you might have that we could look at with ultrasound, because it's so interactive, and we love to educate our patients when we're looking at the screen and we're talking about, oh, we see this, we see that. And we teach the patients while they're looking at their own body, which is very, very exciting to the patient to see what they look like. And it's exciting to us to actually see that individual patient. We love the models and being able to take a model off the shelf and go, this is your knee and this is how it works. But it's even more exciting to go, this is the 3D of it here. And then this is the 2D image on the screen. And to put those together really helps patients understand and see what's going on and how they can change it or how they can stop hurting it is one of the big clues. And so that really works when you combine those two types of education. Next. So what are we looking at? As we've talked about a teensy bit, what we're looking at when we look at those grayscale images, and the one that most people have seen is a baby or a sonogram. So when we're looking at that, you notice that there is black, which is the fluid. Water shows up as black because there's no reflection in it. The sound beam just goes through the fluid. And then everything that has density or that is a little bit thick, the sound wave will bounce off of and come back to the transducer head. So when the sound wave goes out and bounces against something and comes back, then it provides that gray image. And if it's just slightly coming back, it'll be a very light gray. If it comes back harder and faster and harder and faster and harder and faster, then it becomes whiter, as in the color, whiter and whiter and whiter. Okay, so if something is really stiff and really dense, like bone, it's bright white. If something is a little bit less stiff, then it might be bright white, but it might have a little bit of grayish or a little bit of speckly black within it, because a ligament has to have fluid in it too, right? So those things might not be quite as solid white as a bone is. And then you have your tendons that are kind of look like a rope. And then we have muscles that are very, very black, because, and we'll talk about why, but as something gets more and more fluid in it, it becomes darker and darker and darker, okay? But the things that the sound beams reflect off of is what gives us the different colors of gray. as we look at an ultrasound image. Okay, next. So let's take a look at what's normal before we look at what's not normal. All right, here we go. Now, when we're looking at normal, we're going to start with muscle. So muscle looks, this is an image of an elbow, and it's a beautiful elbow. But when we're looking at this, we are looking at this top entire amount of tissue that looks like a steak. Okay, that whole amount of tissue there with the little stripes through it, that's all muscle. And it's beautiful muscle, and the muscle fibers themselves are 70% water. So you need to stay hydrated, especially if you're working out, especially if you want to keep your muscle. Older folks that start to lose muscle mass, a lot of it is hydration. So you really need to stay hydrated if you want to have good muscle function. So your muscle is 70% water, which is why it looks so dark on an ultrasound image. Now, those little white stripes through it, the little teeny ones here and there, those are what we call septae. No, that's a big one that we're going to do in a minute. I don't have the pointer, Natalia does. So we're doing this tandem here. So I'll be telling the pointer where to go. Okay, so the little teeny speckly septae that's in the black, but it's just speckles, it's not really a solid line. Those are septae, and that's like where the microscopic muscle fibers that look like hairs, when they're wrapped all together, maybe 100,000 of them, those are little septae within one muscle bundle. And then the muscle bundles are the little teeny septae. And then the big white lines, that's individual muscles. So that's one individual muscle line that's like encapsulated like that. And then it sits next to another muscle. There you go. So those are two muscles sitting next to each other. And those are the ones, because this is the front of an elbow that you're looking at. And so these are the muscles that do this with your fingers. So all of those little bands that you see there with their own little envelope, those are all the muscles that are going to be working your fingers. So if we ask a patient to do that, we can actually see them work individually and slide and glide over each other. It's like Disneyland for a physical therapist, okay? So we get really excited about this. Okay, so that's what happens with the muscle. Next. Okay, the next one we're going to look at, again, we want to see the black things and why are they black? And the two things we always get asked about with patients is why are the muscles so dark? And why are these little areas over the bone dark? And cartilage, that slippery, slimy surface right on the end of every bone called hyaline cartilage, not your meniscus cartilage, which is the shock absorber in your knee or in your spine, like the discs. That's shock absorber. This is not shock absorber. This is the slimy, slick cartilage at the end of the bone, so that when we're bending and flexing, we don't feel anything if we've never had damage to the joint, because one end of the bone has this slick hyaline cartilage on it, and the other end of the bone has slick, slimy cartilage on it. And then the fluid inside is like oil, synovial fluid. And so you don't feel any friction. So the cartilage on the end of our bones in specific places in your body, they have 80% water. That's why they're so slick and slimy. So they're 80% water. And because of that, they show up black on a musculoskeletal ultrasound scan. Okay, so again, stay hydrated. So let's see the next one. Help your cartilage out. All right, now this is where anatomy and knowledge of anatomy comes in again. So the people that do the ultrasounds in your clinics are very, very good, and they have a very good background in anatomy. So if we're looking at an adult knee on your left and a pediatric knee on your right, you would go, wow, something is wrong here, but it's not. These are both perfectly healthy knees, okay? So where you're seeing the blue arrow, if you follow that white line as it goes along the bottom there, that's the femur, okay? So these knees are at a little bit different angle. The adult knee on the left is the patient's femur is sitting like this, and the pediatric knee on the right, the femur is sitting like this, okay? So, but it's the same bone. That's a femur and a femur. And then, but do you see on the right, let's go to the pediatric picture. There you go. You follow the femur bone, and then it looks like it's broken. and then it has a rounded head. Okay, that's not broken. That's a growth plate. All right, so that's completely normal. This was a 3-year-old. So this is completely normal. Now you notice on the adult side, let's go back to adult, there is no growth plate. It just goes straight through there, and then it goes down into the joint, and we don't see anything else. On the side of the pediatric picture, we have growth plate on the right. Okay, and as the top of the femur is rounded, and look at that black space from the femur up to a line. Okay, everything between that line and down to the bone, that's cartilage. That's not swelling. That's not a bleed. That's cartilage. Because remember, when we're born, our bones are all cartilage. They're soft, they're mushy. And so as they're developing, or well, they're ossifying, that means it's turning into bone. Before they ossify fully, we have these large ossification centers. So if you don't know that this is normal for a child, you would look at this and go, oh my gosh, they're so swollen or bleeding or something is not right. But this is normal for a 3-year-old. So if we look up on the pediatric side, go to where that floating piece of bone is, that floating white thing, flying saucer. Okay, the flying saucer over there, that's the kneecap. That's the center of the kneecap. But everything from the bone upward to where the tissue starts, and everything downward from the bone down there, not all the way through, but if you just imagine that line that we were looking at before, going all the way around the femur top, okay, from there down, that's all cartilage. And so the patella, or the kneecap, is mostly cartilage. So the flying saucer on up and the flying saucer to the tissue and all the way around there, that's just a big layer of cartilage that has not ossified yet. And so this is a normal image of a 3-year-old knee and a normal image of about a 45-year-old knee. And neither one of them have any swelling. All right. So again, you just have to know what you would expect to see as normal. It's age appropriate, and you have to know what structures you would be looking at that are normal or not normal when you put your eyes on these, so that you know what you're looking at. Okay, next one. So when we're looking at fluid again, fluid is black, cartilage is black, and fluid is black. Okay, cartilage is 80% water, and then the fluid we hope is 100% what we call serosanguinous fluid. If it's in a joint, that's joint fluid, and that's synovial fluid made from the synovial lining. So when we look at this, we're going to say, okay, it is the black area between the bone and the capsule, because the capsule is above every joint, so it holds in that greasy fluid we talked about. Okay, next. Okay, did we do this already? Oh, okay. So when we're looking at that, then people will ask us, well, how do you know the difference between what's cartilage and what's just fluid in the joint? The answer to that is anatomy, anatomy, anatomy. Some places in the body have cartilage, some places in the body do not. So the top of this squarish looking bone there, the one on the right-hand arrow, there's no cartilage on top of that bone. So we know the fluid on top of that bone is fluid because there is no cartilage there. But then there is cartilage on the rounded part of the bone on the left. So we know that that is cartilage. And there's another way to know if there's swelling on top of the cartilage. It's called an interface sign, which we do not see here because this is a healthy elbow and there's no fluid in it. And so you would see just that a little teeny faint line, and then more black if there were swelling on top of cartilage. Okay, but we don't see that here. This is a beautiful joint. Next. So now when we look at things, like say some bones have cartilage and some do not. We did that. Go ahead. Next. And when we're looking at the joint, we also see what we call a tornado sign, or a fat pad that comes down at a rounded triangular shape that goes into the joint. It looks like a tornado, so we call it a tornado sign. It's a fat pad. Almost all joints have it, not every one, but most of them do. So if you have a lot of swelling or blood, it'll push that up out of the joint, and then you won't see a nice tornado sign that comes in. It'll be pushed up. You'll see lots more black, and then you also will have a misshapen fat pad. Okay, so that's just a fat pad that most joints have as we move around. It pads the joint as we move. Next. When we look at what else is in our picture, we have capsule, we have ligament, we have tendon. So oftentimes the capsule and the ligaments join together. When they do, you get this bright white area. So it's not bone, it's soft tissue, but because the capsule and the ligaments join together and they go one on top of each other, sometimes the deep layer of the ligaments are the top layer of the capsule. And so you get this really thick, really dense material, and it shows up as a bright white. Okay, next. So now let's look at what's not normal. Let's look at the things of what we see on ultrasound when we look at joints of people who have had bleeds. Okay, next. So on your left, this is a fairly healthy knee, and look at the bone line, gorgeous, beautiful. Okay, the bone line is the white line on the bottom, and it has a little bit right where the pointer is now. It has that little kind of a, what we call it, feathering of the bone. And that just means there's a little deterioration. This person's about 45, so they've had a little wear and tear, but you know what? That's a good looking joint. And that big layer of black on top of it, that's all cartilage. So this person has a nice thick layer of cartilage, which is really sweet. It is a little gray and speckly, but if you look underneath the bone, which we can't see underneath the bone, it should be dark black, and it's kind of speckly under there too. So we know the machine is kind of grainy. So it was done on a different machine. And so we would expect that to kind of be all black as well. And since the cartilage is the same shade of black as the underneath the bone, we would call that good, beautiful cartilage. Okay. It's kind of a grainy machine. So this person has a beautiful knee. Now, if we go to the other side, that is not a good bone. Okay, this is a really, really destructive thing happening to this joint. So we have a horrible bone line, and keep on going. When you get to the bottom of the dip, it even has a dropout where the bone has punched through. Okay, and now keep going, and up at that other side, it has an osteophyte, or what we call a bone spur, or an osteophyte. Now, if you come back over the hump, there we go, and now go up to the top of that gray mushy stuff. All of that is swelling and soft tissue proliferation and the synovial lining that's just thickened out. So all of that is junk that should not be in the joint. And all of that bubble in there, can you just surround that bubbly area there? Yeah, go from where the tissue looks good and just follow it along. Follow it along where the tissue looks nice and healthy. All of that underneath it to the bone is all mushy junk that shouldn't be there. And so this is a really bad joint. Now, if you go all the way to the left-hand side of that picture, see that bright white line where the femur is, because this is your knee. Keep going with the pointer, keep going. Now down, 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 there. The bright white line of the bone, and then that little bit of black above it, that's a good bone and good cartilage. So that whole knee should look like that. Dark black and bright white would be a good bone and cartilage on top. Okay, next. Okay, this is just horrifying. This is so like, wow. Okay, on the right-hand side, on the left-hand side, this is a fairly good image of a shoulder. So all of that starry night kind of speckly stuff you're seeing, that's a muscle. Before you saw the muscle long ways, now you're seeing the muscle cut. So it's looking right at you. So all of those little white speckly bands, now you're seeing them this way. So they look like little bristles coming at you. So those are all the little coverings of the bundles and the envelopes of the muscle, the white stuff you see in that muscle, that's your deltoid. Okay, then you see the bony, the contour, down a little farther, there. So that's the bone, just follow it along to the right, and it'll drop down into that little divot. There you go, drop it. And then there's more white bone at the bottom. Keep going, there. Okay, so that's called your bicipital groove. So that little round thing in there is your biceps tendon, right? The little round entity above there, that's all biceps, the whole thing, the whole round thing there, that's all biceps tendon. And then if you go to your right, This person has a little bit of biceps tendonitis, so you have a little fluid, the black stuff that comes out and over that rim. That's, and go to your left, your right some more. There you go, and down. That's all fluid, that's biceps tendonitis. Okay, so they have a little bit of fluid in there. But so that's a fairly normal shoulder. But now if you go to the one on the right, oh my goodness, follow that bone line again. There you go, go down into the dip. That's your bicipital groove. And now go ahead, and we want to go more to the right there and up that blob right there. That blob is blood, fluid and blood in the joint. And that's a recent bleed because it's dark. So it has a lot of fluid in it. And now see those little gray speckles? All those little gray speckles are the heme in the blood that's reflecting. So the heme gives us a reflector. So we know it's just not black fluid like it is when you see it around a baby or in a joint with no problem. When we see the speckles in the black fluid, we know that there's blood present. Now, if you go further to the right and you see it kind of, I'm sorry, to the left, you see it kind of globby. Go out, there you go. And all those little globs right there, that's old blood that's organized a little bit. And now go farther to the left. And this is a medium age bleed. So the glob on the right is a fresh bleed. The glob in the middle is an older kind of organized bleed. The glob farther to the left is a medium age bleed. And see where there's several shades of gray there? There's a darker gray, then there's a lighter gray, and then there's kind of speckly in the darker material there. All of those different shades tell us about the blood. How old is it? Is it settling along the outside curve and outside lines of the synovium? Is it settled out? Does it have fibrin strands? So all of that tells us about the age of the bleed. How recent is it? 1 day, 2 days, 3 days, 4 days, a week. So now let's go to the next slide. This is another one. This is a video clip, but it's not working right now. So it's the same image that we just looked at. Okay, next. So now this one is the same exact shoulder, the one that had the bleed, 2 weeks later after multiple infusions. So you can see that the blood has separated out and it's sticking to the sides a little bit more. You can start to see the fibrinogen coming in and going across that area. And now it's getting more normal joint fluid in the middle where it just looks black. It's not really speckly in the middle anymore. Now that grayish speckle is going toward the outside. So that's an older bleed that's having some resolution and it's healing and getting better. Okay, next. This shows a Doppler. There's 2 Dopplers in ultrasound. One Doppler is called color Doppler, and that does, how strong is the blood flow, one direction or the other? And is it going, whoop? Is it stopping, or do you have a blood clot? Okay, that's color Doppler. We're looking at power Doppler. Power Doppler shows us microvascularity. So with microvascularity, it tells us what kind of, how inflamed it is, how much it's coming in to try to heal it, and how much percolating little blood vessels are in there trying to heal that tissue. So you can see around the edges of this old bleed, and old, I mean 2 weeks or so. This was the picture from just before. Then we're having some inflammatory processes go on that are helping us to heal this tissue. So this is still a bit inflamed, quite a bit inflamed. This would be a grade 3. We grade at 1, 2s, and 3s. So this would be a grade 3 inflammation still going on in this shoulder. So they would still be on anti-inflammatories as well as whatever the blood products that the doctor had suggested. Okay, continue. And icing, there would still be icing. Okay, now this is a normal ankle on the top left. So you want to see that nice, beautiful dome of the ankle where the black arrows are pointing at it, and then the black and the white arrow. So all of those, that area between those arrows is beautiful dome of the talus. And then on the far left of the images where it goes bloop and rounded, that's the end of your tibia. This is in your leg and your ankle, okay? So this is the bottom of the tibia, and then that rounded bone is the first bone of your ankle in your foot. Well, that's what it should look like up in the top left. This is a patient ankle that's had a lot of ankle problems and bleeds, the one in the center that looks kind of grayish. So this is your tibia, your leg bone coming down, and you can see as it comes over that corner, can you point as it bone comes over the over that corner, then it goes spiky and you have a little bone spur there. And every time this patient would move their ankle like this, that bone spur was going. And so where it should have been a dome, it rubbed it off and it scraped off all that bone. And so it's not rounded anymore. It's that straight, and it's almost starting to go inward and getting that straight plane on it. So this patient he does have motion of his ankle, but it's very painful. So with physical therapy, we would look at this image with the patient moving and that bone spur going every time. And we would go, okay, we might want you to do some exercises, but we don't want you to go past this because we don't want the bone spur to go there. All right. So, and if we were going to do some work, we would distract it first, and then we would do some movement work on it. So it tells us what we can and cannot do as we work with this patient. Okay, next. So when we look at ultrasound, there are several reasons why it's super, super good. Okay, well, there's many. There's no radiation, there's no sedation for children, and it's very inexpensive. It can be used on site, and we can compare it to the opposite side with no radiation. There's no exposure to anything that's negative. Next. It can be given in a timely fashion to see if there's bleed or no bleed, so that the doctor can get real-time results and decide whether or not they want to change factor protocols, whether or not they want to give anti-inflammatories, whether or not they want to refer for further workup. So they can see that immediately. They don't go, let's get an MRI or an ultrasound if you're doing it outside the clinic, and you wait a week, you wait 3 days even. Well, you don't have the same problem with a patient with a bleeding disorder. So we need to get it the same, hopefully the same hour, the same day, and so that we can get those answers, bleed or no bleed, do we need factor, do we need anti-inflammatories, not factor, or do we need something else? You can have an immediate comparison with the healthy side, and you have excellent resolution or focus because of the pixel size, and we also get the entire contour of the surface because it is not done by averaging. We see the entire contour, and it can be portable. You can use your laptop or your handheld, and it can be a portable device for you. Next. There are 2 drawbacks. And the first is that this is very, very operator dependent, which means that the operator, if the operator isn't any good, the images you're going to see are not going to be any good. So the person doing the ultrasound has to be good at doing ultrasound. So it does take a lot of training. It does take a lot of knowledge of anatomy, as well as how to get a good image. And so there has to be continued training for the sonographer, whoever's going to do that, usually the physical therapist or a nurse or physician at your center, but they need to go every year, every 2 years for ongoing training, which we usually do anyway. That's nothing new. And we can't see through bones. So if there's anything inside the joint, if there's anything interior, then you do need an MRI or a CT scan, because we just see the outsides. Even the meniscus of the knee, we see the outside edge, and we don't see the whole depth of the meniscus throughout the joint. Next. Thank you. So that was it. We're going to do some housekeeping a little bit. We want to do an evaluation. I'm going to turn that back over to Natalia. So I won't see any of this. So you guys can do your own thing and say what you want on the evaluations. And then she's going to come back and we're going to share again. And then you can ask all your questions. All righty? Okay, here we go.
All right, thank you, everyone. We are going to go through a couple of evaluations, but first we want to give a special thank you to Santa Fe Genzyme for supporting the development of this workshop. All right, and we also want to say thank you to all of our community education sponsors. There's a whole bunch on here, but thank you. Without those sponsors, we could not put on this type of programming, so thank you. And then we have a couple of slides here. We definitely want your feedback. So if you can please, again, go to www.minty.com, use the code at the top of your screen, and go ahead and put in a couple of your points of feedback for us. We would greatly appreciate it. And results aren't going to come up on the screen, so we won't see anything. But we do have 3 slides, so you all can again go to menti.com, put in the code at the top of the screen, and give us some a little bit of feedback. We would greatly appreciate it. All right, another couple seconds and we'll move on to our next question. And then if you can go ahead and go into menti.com, use the code at the top of the screen, and then tell us what your main takeaway from today's presentation was, that would be great. And I'm seeing your comment, Priscilla, in the chat. If you want to maybe private chat that to me, that would be awesome. And I'll go ahead and put that feedback into our notes as well. All right, I'm going to leave this open just for a little bit longer and we'll move on to our next slide. All right, I'll go ahead and move on to our next slide. If you can go ahead and please share any additional comments. Again, results aren't going to be displayed on the screen. We greatly appreciate your feedback.
While you guys are doing that, Naomi replied that her son at age of 13 had a radial head excision. So this was interesting. What's really interesting about radial head excisions is where you saw that little square part of the bone and then the round part of the bone on the elbow. That's when you see an x-ray or a muscus image of someone who's had a radial head excision, that square part of the bone is just gone. And the first time I saw one of those images, I was like, what's wrong with the machine? Because it's not showing us the bone, but it literally is just not there. So it's really an interesting image, but yes, it would be really interesting to show that on an ultrasound or even on a plain film x-ray. It looks very, very like out of this world. Someone is missing part of a bone and they're functioning just fine.
I think that's all the evaluation we have. So Cindy, we are open for questions.
All right. So anybody have a question, go ahead and put it in the chat box and we will see what we can do. If you have questions about specific images, just say, the image of the round thing or the image with lots of swelling in it or whatever, and we'll try to find the one you have a question about. And this is just one of my favorite things to do in clinic now when we have time. We don't always have time, but when we have time, we'll just grab somebody and practice. But it is super exciting because it's one of the only times we can answer a question for sure right now. And that's really exciting to us as well as the patient. So it's really a nice modality to use. Okay. And arthritis, what is a bleed and what is arthritis? Aha. So the question is, what is a bleed and what is arthritis? And it is, a bleed is the synovial, this is a joint. Okay, so the synovial lining inside the joint is much like the mucous membrane inside your mouth. So when that gets pinched, like if you bite your cheek, and the same thing happens if I have my knee and I'm turning over in bed or I'm turning over, it's like my two bones go and pinch the side of my capsule that's right here. So if my capsule is here and the bones go like that, just when I turn over, when I move, or if I flex and stand and rotate my elbow, it can pinch the side of the capsule, just like my teeth can bite the inside of my cheek. Sometimes I don't even know it, that it's happened inside of a joint because I don't have as many pain receptors as I do here, but it still happens. And so it'll cause a teensy weensy little bleed inside your joint capsule. And that's very sensitive to blood, the enzymes, as blood breaks down, as blood gets in there, the enzymes from the blood inflame it. And so then you get this thickness and you get a thicker capsule. When you get a thicker capsule, just like when you bite your cheek, that spot gets easier to bite again. It happens in the joint. So when you pinch that membrane, it inflames and it swells, and then it's easier to pinch again and pinch again. So the synovium gets thicker and thicker around the joint, and it continues to bleed until for some reason, somehow, we can get that to calm down and thin out again. And then you get your normal joint back. So that's a bleed in a joint. Arthritis is when the bony shapes and the cartilage start to deform and become destructive. So as we destroy that nice, beautiful cartilage, that's arthritis. So a bleed is just blood in the joint for whatever reason, whether it's a contusion or whether it's a pinch. And arthritis is when you've had so much damage over time that the cartilage and the bone configuration has started to change. That's arthritis. So that's the difference between a bleed and an arthritis. Okay.
I think we have time for maybe one more question.
Yeah.
It looks like there's two there from Christina.
I'm not sure about my back. I just got out. Yeah. Oh, darn. Okay. And yes. Okay. Microbleeds. Do not believe that. Okay. I know. Well, okay. This is why they don't call them microbleeds. Microbleeds are what we would consider, why some people say, yes, you have microbleeds, and some people say, no, you don't. Microbleeds depends on the language being used. So yes, I agree with hematologists saying that a microbleed doesn't exist, but I agree with people who say little teeny bleeds exist. Okay, so a microbleed in that you have these bleeds all the time and no one knows about it and your tissue is not doing your tissue is not responding. I don't agree with that. But if you're having something happen that your tissue is responding to, your tissue is inflamed, or your tissue is, you're actually seeing and feeling the swelling of the heat and the warmth, as well as redness and the puffiness, then something's happening. And so the nice thing about doing an ultrasound right away is we can see what that is. Is it just soft tissue proliferation where something has, like say, if we can do dynamic imaging and see if something's being pinched. And so you have inflammation from something being pinched as something moves past it. And that can create inflammation without creating a bleed. So inflammation does not always include a bleed, because just tissue, if you just pinch your finger, it can get swollen and inflamed, but there's no blood. So I think that's the differentiation that the hematologists are using, is you can have inflammation and you can have things ongoing inside a joint or a soft tissue area. That's not necessarily a bleed. So not everything that is felt that is swollen and hot and warm is a microbleed or a bleed, but you certainly can have really teeny small bleeds that continue to degenerate the cartilage and degenerate the bone if it truly is a bleed. But then it should show up on an ultrasound, or there's another test you can get. If they've done all types of diagnostic things and they can't figure it out, an MRI will show if there's hemosiderin, which is the heme, the iron portion of the red blood cell. If there have been microbleeds over a long period of time, sometimes the cartilage will absorb some of that, and you'll have what they call hemosiderin deposition on the inside of the synovium or on the cartilage area. So you can see if people have been bleeding over time, which some people would consider microbleeds. Other hematologists would say, no, you either have a bleed right now or you don't, but some of that blood will be left over anyway. So are you having some blood product in a joint over time that will keep it inflamed? And then there'll be some hemosiderin deposition in different places. So there are a couple of ways you can kind of try to weed it out, but I can see some hematologists just say, no, we don't call it a microbleed. And others will say, well, you do have small bleeding occurring if you're continuing to pinch that area as you turn over in bed or as you do this, and it's already swollen. So kind of 6 of one, half dozen of the other. But is there something ongoing in your joint that's keeping it inflamed? Hey, we need to know. And so let's get to the bottom of it. And ultrasound is one of the many tools they can use to try to get to the end of a diagnosis for you. Hopefully that helps. Okay. Should microbleeds be treated? That's not my ballpark. That would be something that you have to work out with your hematologist. I'm a physical therapist. And so that would be something where if it's not a microbleed, but it's just an inflammatory process, an anti-inflammatory might be a better treatment than a blood product or an infusion product. So like I say, you need to get to the bottom of, is this chronic inflammation, or is this bleeding that's occurring just at a lower level? So 6 to 1, half dozen of the other. Again, you have to figure out which one it is to know whether you treat with anti-inflammatory or whether you treat with some type of product.